So, how you like that new music? I like that. Today we're going to be taking another swat at the medical industrial complex. If you haven't heard that term, it goes all the way back to World War II. During Dwight Eisenhower's presidency, the military machine became such a big thing, it had a huge impact on the economy. Well, that was back post-World War II. These days, the medical machine has a huge impact on the economy. And why do I talk about that? Because it impacts healthcare. Today, for example, we're going to talk about yet another big money maker, and the fact that it may be a moneymaker for cardiologists and cardiology clinics and hospitals, but maybe you need to dig a little bit deeper, because it might not be providing you medical benefit, like it's providing others financial benefit. We've already seen that multiple times. We've seen that with stents, with the Orbiter trial, the Courage trial. Those trials actually did blinded studies where they took people in, half the people, they took a group of people. I think this was the Orbiter trial, where it happened in the UK because the US human subjects trials ethics committees wouldn't agree to it. They took people in that were going to get a stent, and they randomized them to one group got a stent, the other group didn't. They took them into the OR. They did everything the same. So the patient didn't know that they didn't get a stent. Guess who did better? Neither one. Getting a stent did not prevent a heart attack. So the Courage trial had happened before that and showed the same thing. Guess what? How many stents has that? You would think that that would really decrease the number of stents being put in people, wouldn't you? Well, it didn't. And guess what happened next? So one group of the medical industrial complex, and I'll let you guess who, said, oh, well, guess what? That just proves that stents don't work. We're going to have to do bypasses on everybody. Well, then along came the ischemia trials. Guess what they showed? In the vast majority of cases, bypass doesn't prevent heart attack either. So, it's interesting. I've actually heard a thoracic surgeon, a cardiac surgeon, say this. His quote was, I think that the medical community needs to apologize to our patients that we've done all this work on for no help. And in fact, it obviously hurt a lot of people. When I heard him say that, I became a big fan. His name is Philip Avadya. You may have heard him on, I know a lot of people, the AI has told me a lot of people watched that interview. Dr. Avadya is the author of Stay Off of My Operating Table. He is the cardiac surgeon. He's started to change his activities. He still does cardiac surgery, but now he's changed his practice as well. He's got a side practice doing something similar to what I do, helping people get back into metabolic shape. So I'm going to be having him on the channel. I think it's like in a couple of weeks, maybe early August. Now, this is not going to be a replay of his discussions with Ken Berry. I'm going to get a lot deeper and a lot more personal. And we'll also talk about some other things as well. But many of you don't know. He mentioned it briefly, but most people didn't pick it up. Dr. Avadya had his own personal problem with obesity, his own food addictions, just like I've had my own food addictions. And we're going to dive a little bit deeper into that. We're also going to talk a little bit more about some of the technical issues involved in this space. So again, back to the point, we are finally getting people starting to say, the medical industrial complex hasn't been doing what it's supposed to do. Guess what? We're going to be covering a study today about angiograms, going to the cath lab. And does going to the cath lab, is it really in your best interest? Maybe not, according to the New England Journal of Medicine, or at least an article, front page article in the New England Journal. We'll talk about that a little bit later in the presentation today. For those of you who haven't joined, or if you've seen our stuff, you're just wondering what other content. More recently, we've talked about the worst ingredient for your immune system. And I suspect if you've seen much of this channel, you might know what we're talking about. There is one set of foods that really messes up your immune system and your ability to fight off infections like the pandemic. And again, we covered articles which demonstrated that. Long COVID, more than just a flu. There's been more and more information coming out about it's far more prevalent than we think. A lot of people thought, well, this whole thing about COVID was made up. No, it's not. COVID is more than a flu, and it's been a challenge. There's a lot of people with long COVID that we didn't expect. A lot of people are shedding COVID virus much, much later, weeks and months later. One of the biggest, most dramatic things that I see impacting my practice is people are going along with this level of prediabetes or diabetes, insulin resistance. Then they get COVID. They get over the COVID, but we test them again with an OGTT and IR, and their insulin resistance has cranked way up. We're seeing a lot of that right now. We're seeing a lot of inflammation. The other thing that happens acutely is C-reactive protein, especially, but PLA2. Both of those are tending to go up significantly for a few weeks when people get COVID infection. So we cover a little bit more of the evidence around what's going on there. And again, I get technical. I'm a doc. I talk about doctor stuff because unfortunately, doctors don't know enough about the things that really cause your death and disability. You have to learn some of it on your own. But getting hammered with all of my overly technical stuff sometimes makes you want to just hear from a patient. So we get patients on every few weeks, and Lois came back. Lois has talked a couple of times. She was one of those suspenders in a belt people. What do I mean by that? She was doing the right thing in terms of preventing her cardiovascular event, despite having very significant issues, FH, familial hypercholesterolemia, as well as some other stuff. But she also had family concerns to think about in terms of saying, nah, I don't want to have that stent. I don't want to have that bypass. And she ended up getting the bypass and shared her story. It was a very interesting and fun story. It gets into a lot of the emotional and existential stuff that that becomes an issue when we start thinking about the stuff we do for a living: stents, bypasses, and prevention. I don't do stents. I don't do bypasses. I feel like, for example, I just had a hunch 30 years ago that I was very interested. The part of medicine that I loved the most was procedures, but I just didn't see procedures making a difference. So Dr. Avadya decades ago went the surgery route. I went the prevention route. Now Dr. Avadya is having to do a 180 and come back to the prevention route. I mentioned a minute ago that your doc probably doesn't know how to diagnose, let alone manage what's killing or disabling you. we've got courses. We've developed a core curriculum talking about insulin resistance, plaque, how to assess plaque in your arteries and whether or not that's dangerous. And again, as we'll see today, the best way to assess plaque is not the way that the medical community is doing it right now, taking you to the cath lab. We've known that before. This is just another article coming from the New England Journal, from the standards makers in medicine, that's the case. And then there's some things called cardiovascular inflammation. We go into some detail on helping you understand that, because again, the science is also really clear about what doctors do and do not know. The docs that manage the vast majority of this issue, family practitioners, cardiologists, internists, 2/3 of those three groups don't understand how to diagnose the major underlying problem, insulin resistance, let alone manage it. So again, unfortunately, patient beware. And if you have a problem, these courses tend to be not hidden behind a paywall. If you're trying to get one of these courses, and you have a challenge, usually at most they cost $15 to $40. If you have a challenge with paying that, we'll check in with Michelle. We'll get it to you for free. We're getting, as you might have noticed, the content's getting more and more popular. It's all over the world right now. Less than half of it's being consumed in the U.S. China, for example, is the number 5 country in terms of the number of downloads of the podcast content. We've recently expanded our options for, we developed a YouTube channel. That's how to join it if you'd like. We're on Locals and Rumble now. If your place on the internet is Locals or Rumble. I will tell you this, we are looking at the potential. I've been eyeball deep in terms of some transitions and bringing on large investors for the Alabama project. What we've done, learned in the Alabama project is making us rethink how we're set up with our current channel practice. We are very seriously considering accepting Medicare and other insurance programs for the channel practice. If we do that, that'll create some changes, a lot of changes. We would love to hear that if you have an opinion or reaction to it. As I've seen patients over the past month or so, I've shared this with them, and at least 80% of them are saying, oh yeah, that would be great. It would greatly improve the access. And I've got about 5 family members that I'd love to have see you as well. So love to have some conversation about that a little bit later during the Q&A section. Now, for the mini topic for today, this is about polycystic ovarian disease. Interesting, or syndrome. As many of us know, it's very much associated with diabetes, prediabetes. Women with polycystic ovary syndrome have insulin resistance and hyperinsulinemia. Now, this was an interesting article, New England Journal this year, and it's basically looking at the potential for, there's a potential deficiency that might be causing a large part of this. And when you see that kind of study, looking at causality of a disease or a syndrome, the next question is, okay, what can be done to cure that? Or can fixing that problem cure or prevent the disease? So here's what they did. The authors measured steroids in serum and performed an OGTT before and after a 1,200 milligram dose of D-chiro-inositol or placebo once daily for 6 to 8 weeks in 44 women. The D-chiro-inositol increases the action of insulin in patients with polycystic ovarian syndrome, improved testosterone, blood pressure, triglycerides. In other words, the inositol looked like it helped. This is way too small a study to to say, oh, we've got a cure. That's a gross over interpretation, but it's a very strong signal. I mean, that's why it's in the #1 journal of medicine in the world. It's a very strong signal that we may be having some chipping away at PCOS, polycystic ovarian syndrome. So, if you'll give us the water ball, Gilbert, we'll go into the long form content for today. So this is one of those articles, and when I first started thinking about doing a YouTube channel, one of the things I thought about is, your typical YouTube channel is somebody pushing on supplements or pushing on something that they had an idea about and really talking about their idea. That's, we do a little of that, but not very much. My interest has been looking at the science that's out there in medicine, and science that maybe needs a little bit of an interpretation. So, for example, your typical non-medical person, if they were to see this title, "Is CTA better than an angiogram?" they're not going to have a clue. What does that mean? This is likely to get written up in New York Times, some of the larger journals, but it's not going to be that clear even then. And so here's what this means. Again, what they're doing is comparing CT angiogram, a very simple, non-invasive procedure for looking at plaque. We've talked about that many times. If you get the book, if you've read the book, it's one of the 3 items that we recommend. For example, in the book, we said, no, there are a whole bunch of ways of evaluating plaque. One is just the simple, oh gosh, I'm having a senior moment. Somebody help me out. It's the questionnaire. It's named after the town near about an hour from Harvard. Anyhow, the questionnaire that docs always do, and they do it wrong. That questionnaire is wrong. There's a lot of problems with it. We go into detail on why that's not enough. Then the next one is, okay, well, maybe I've got risk. Let's measure and see if I've got plaque by doing a stress test. There's all kinds of problems with stress tests. One of the biggest problem with stress tests is it's only positive if you've got over half of your flow blocked. Well, 2/3 of heart attacks occur in people that don't have over half of their flow blocked. That's a problem. So then the next very popular way of looking at plaque is ICA here, or coronary angiogram, the cath lab. So again, one of the things that I mentioned multiple times in the book is, if the doc wants to take you to the cath lab, be afraid, be very afraid, think through it 2 or 3 times. Now, in the book and in our discussions about ways of evaluating plaque, we've recommended 3 others besides the questionnaire, whose name I cannot remember right now, and the stress test and the cath. The 3 things that I recommended were CT angiogram as a big up-and-comer, but also a calcium score and CIMT. Each one of these items, every one of them has its problems. But again, the guys that are looking at changing things in medicine, the #1 journal in the world in this space right now, New England Journal of Medicine, is publishing something that's a big deal in this area. They took one of them that we recommended, CT angiogram, and they compared it to going to the cath lab. So here, let me go to the script here. It's CT versus invasive angiography, ICA. Invasive cardiac angiography. That's what ICA means, by the way. The discharge trial. So the authors compared the effectiveness of CT angiogram. And let me just stop and explain that. CT angiogram is where you do use some radioactive dye. You inject it down into a place like a vein in the arm. You don't have to thread a cath up into the heart. ICA is a cath lab. They go into your groin usually and thread a catheter up into the heart. That's how they do that. Very invasive, mega dollars to the patient. I mean, very invasive compared to CT angiogram. I go into the details. The biggest concern that I have about a cath angiogram is not really the invasiveness, although we'll see that becomes a big issue in this study. The bigger issue that I have with a cath lab angiogram is that it's taking you down that path. You see some plaque on there. You think it's your cardiologist sees plaque. If you're a hammer, everything looks like a nail. They'll even ask you to sign off on letting them put a stent in before they even go in. That's the standard. And so again, you've gotten not one, but two procedures, which have now been shown to not be effective for you. So anyhow, this is a randomized clinical trial. It's comparing CT angiogram versus invasive cardiac angiogram or cath lab as initial diagnostic images for guiding treatment in patients with stable chest pain who had an intermediate pretest coronary artery disease. The study was a large one. It included 3,561 patients. 56% were women. The follow-up was for a 3.5-year period. The primary outcome was major adverse cardiovascular events, cardiovascular death, non-fatal heart attack or myocardial infarction, or non-fatal stroke. Key secondary outcomes were procedure-related complications and angina. The study was conducted from 2015 to 2019 at 26 European centers. And as you can see, the publication date was April of 2022. So they were doing this study when I was writing the book. And again, what that shows you is that even though this is New England Journal level material, most of this information was already known. It's just taking forever. It takes forever to get standards changes in medical care. And we've talked about one of the reasons why. There are multiple reasons, but the financial inertia is a big, big problem. So the discharge trial results, 3,523 patients completed the follow-up. Major cardiovascular events occurred in 2.1% of patients in the CT group and 3% in the cath group. Major procedure-related complications occurred in 0.5% of patients in the CT group and 1.9% in the cath group. 11% of patients in the CT group underwent percutaneous stent compared to 14.4% in the cath. So you may say, well, gosh, you know what? They're more likely to have a bad outcome. They're more likely to have more surgical procedures, and they're more likely to have cardiovascular events. When you actually look at those differences, they weren't so much the one that was major, that showed statistical significance was the fact that was the complication rate. The 1.9% in the cath versus the 0.5% in patients with a CT. Again, as I would say, this is one of those areas. I'm doing two things in this channel. One is presenting information that you might not even take a deeper look at. The other thing I do is I performed and trained as an epidemiologist at Hopkins. An epidemiologist looks at, dissects, and analyzes studies like this. And this is one of the areas that I would tell you, yep, it's not that difficult. If you've got a complication rate 4 times that, it's not going to be that difficult for CT to show a statistically significant, safer component. These other items suffered. They weren't quite as strong in terms of statistical significance. Let me give you the other epidemiologist's perspective on that. Even though the cath lab showed 4 times the amount of complications, it's still not a huge, dangerous amount of complications. Again, as I said, these complications aren't the problem. The problem is going down that path and getting the stent or the bypass. So among patients referred for cath because of stable chest pain and intermediate pretest probability of coronary artery disease, the risk of major cardiovascular events was similar in the CT group and the ICA. That's what I was just saying a minute ago. It was a little bit higher among the cath group, but not statistically significant. Procedure-related complication was lower with the initial CT strategy. So what does all this mean? Like I said, think once, think twice, and run the other way if your doc wants to do a stent or a bypass or a cath. So if you'll take us to the transition for Q&A, we will talk about questions and answers today. So we got John Tucho. John saying, schedule an appointment with my doc to talk about Ozempic. Thank you, Dr. Brewer, for last week's presentation. So very important. I will tell you, again, these are one of the things that's happening, and I'll share my my response. Glad to hear that, John. I'm hearing there's a run on Ozempic. There's just more and more people are finding out about the outcomes of these cardiovascular outcomes trials. And they're saying, hey, you know what? And there's a big weight loss component as well. Like any other, especially prescription drugs, these have their side effects. But a couple of things I'll tell you about my own experience over the past month. I have been well known, and recognized within my family and with people that I work with for the ability to keep weight off. I thought I knew that I had issues. I grew up in I've had my food addictions, especially with sweets. I grew up in South Carolina, the land of sweet tea and blackberry cobbler. But I did not know how much it was my yellow water. I grew up in it. I was born in it. I did not know how much I was constantly fighting being hungry until trying doing that 1-month trial of Ozempic. I'm going to continue to do it. Again, the point wasn't weight loss, although I could stand and did. I've lost like 10 pounds. The big issue is that these are saving lives. They're preventing cardiovascular outcomes. And like I said, I take my doctor hat off and put my patient hat on. There's a book called Always Hungry. It was written by David Ludwig, an endocrinologist and the head of the Harvard Obesity Management Clinic. And he's talking about how those of us with obesity problems, with weight gain problems, and his perspective is just insulin resistance. We have no idea how much we spend all day being always hungry. His resolution to that, he wrote that book prior to the GLP-1s coming out. And his perspective was, number one, just get off the carbs first, because those carbs put you in this blood sugar roller coaster. You get hungry, your blood sugar starts going low. You eat something that's got carbs in it, your blood sugar goes, from 80, 90, 100 up to 140, 150, 160. Then you overreact, your insulin overreacts, and then you start diving back down. That kind of roller coaster with blood sugar really impacts your hunger. Another interesting surprise that I had, I knew that it dropped blood sugar levels. Mine dropped about, on the average, 20 to 30 points on a regular basis. Very, very interesting reactions. So thank you, John. I appreciate it. And again, today we'll see that cardiac cath doesn't work either. More beatings and more loss of ground for the medical industrial complex. And I think any of us can guess the Orbiter trial, the Courage trial didn't do away with stents. In fact, they did more. More were being done. The ischemia trials aren't doing away with bypass grafts. And the discharge trial, I think we can all agree, is not going to do away with the cath lab. Felix Cat, I'm ready, Doc. Thanks, Felix. Amer, good morning from Germany. Good morning to you, Amer. Bobby Ocampo. So, Bobby, I've been pronouncing it wrong. Mabu Hai. I think I got that right. Mabu Hai. That means live long. So thank you so much, Bobby. If those of you who don't know, that's Bobby's in the Philippines, and Mabu Hai is a greeting that means live long. May the Lord continue to bless you for helping save lives. Thank you, Bobby. I appreciate it. Chris Rocket, calcium score was 1900. Angiogram showed 0 blockages. Is this normal, false positive, or should I still worry? Well, you should worry, but here's what you need to know, Chris. I mean, by far the most common reason for people coming to see me is they had a positive calcium score. And here's the question: how much soft plaque? I'm not worried about the calcified plaque in your arteries. That's pretty clear. You look at things like the Honda study, and calcified plaque doesn't cause a heart attack unless it resoftens. But here's what you don't know from that calcium score, Bobby, and that is the problem with calcium scores. You don't know how much soft plaque you've got there. That's what you need to evaluate. Gilbert, if you'll show the phone number for Michelle, Chris Rocket. If you can call Michelle, if you want to come see us, we can help you figure out, do you have soft plaque? Because that's what causes risk. Bart Robinson just got done skipping rope. Oh, that's interesting. I just took up rope skipping about a month ago. I've been watching the jump rope dudes, and there's a lady, English lady named Lauren Jumps, and then there's a fellow named Rushy. I've been watching all those guys, and rope jumping is a big, big cardiovascular deal. So I'm impressed. Rope jumping and burpees. Tuned in as always. So a good day for everyone. Thank you so much, Bart, for sharing that. Bambi Grage, good morning to you, Bambi. And Ewandro Magales, thank you so much. $20 super chat. These super chats are a big deal. They help us get this information out to the world. And for those of you who don't know it, yes, we get feedback every week. Hey, Doc, I started doing some of your testing, and no, I didn't have prediabetes. I had full-blown diabetes, and no, my doctor had no clue. And so therefore I had no clue. And now we're getting some things changed, and this information saved our lives. These super chats, like Awandro just gave us, help us make an impact, because again, as you may or may not know, Gilbert, who's co-hosting with me today, is from the Philippines, and It's a very, very different economic environment there. $20 goes a long way in the Philippines to help us get this content out there and I say get the content out for the rest of the world, because so much of our team is in the Philippines. So thank you again, Oandro. Mezzanine, good morning, Doc. Thanks for all you do. M. Ball, can nurses save their doctors? Well, a lot of them try. A lot of them try to get rid of their doctors. And a lot of them feel like they know a lot more than their doctors. Leo Acapulco, I'd love to be able to do it with my Cigna insurance. If we end up taking Medicare, we're going to look at other key ones. Again, like I said, a lot of what we learned was from our experience down in Alabama, and we clearly take Cigna in Alabama. So I would be surprised if we don't end up with if we go this route, I'd be surprised if we don't end up having some Cigna options. Black Tengu, Dr. Brewer, have you ever been tempted to go for a sandwich, considering it's the bread part that messes you up? Black Tengu, I haven't done it recently, but I'll go through these episodes of eating sandwiches. I do. And here's something that you might want to check out. I've got some of this bread in my freezer today. You go to Amazon, you get low carb or keto bread. And there are actually options out there that don't taste that bad. Now, after it's been frozen for a while, it's not the freshest bread. But here's what I do. I get that keto bread, and I'll do something like make a grilled cheese or one of those paninis. We've got I think is it a George Foreman panini maker? But we've got a panini maker, and that is just really tasty. It's interesting, though. When I first discovered that a couple of years ago, I just thought, man, I can go back to eating sandwiches. But it's kind of weird. Even though these sandwiches are really good, I just don't eat a lot of them anymore. Things change, tastes change. I might have one of those now that you mentioned it, Black Tengu. Bart Robinson, and I'll just say one other thing, which might surprise you. This week is Burger Week in my home, Lexington. And I've been to, I think, 3 or 4 versions of Burger Week this week. But no, I'm not eating the bun. Bart Robinson, I must admit, I'm eating a pork roll, egg, and cheese sandwich right now. Oh, Bart, I hope that's a keto. I was talking with a patient yesterday, and he was saying, this patient is in, it's a patient in Singapore and Malaysia. That obviously doesn't, that's not a HIPAA violation, because there's a heck of a lot of people in Singapore and Malaysia. But he said, oh, I'm doing very bad with my diet. And I started talking to him, and his version of bad with the diet was, he said, well, I never eat bread. I never eat any kind of sandwich, and I never eat rice, which is a big, big deal in that part of the world. But then he went on to say, here, there's a lot of Chinese and egg rolls and kind of stuff. And I'm traveling, so I do eat a little bit of egg roll skin every now and then, because I just can't avoid it. And I'm thinking, that's really not that bad. And we talked about other options, like buying 2 egg rolls, for example, and opening it up and eating the stuffing out of the middle instead of the egg roll covering. Interesting that we got down this carb eating path. Bart Robinson, it's damn tasty. Your pork roll, egg, and cheese sandwich. Pork roll and scrapple, very popular in South Jersey. Yep. My wife's family is from Pennsylvania and Jersey area, and scrapple was their big thing. In the South Carolina, where I'm from, it was sausage. A lot of people had bacon. We had more sausage. Mary Withy, good morning, Doc. Good morning to you, Mary. Iwandro Magales, thank you for all you do, Dr. Brewer. I seem to do best on a little bit of carbs. Do you have a number I could use as a target? 100 to 150 grams per day too much. So no, actually, I've mentioned that several times, and that's the target that I tend to recommend. If it's just somebody coming from the standard American diet or somebody that's not watching carbs, first of all, count your carbs. Secondly, and that people say, oh, that's just too much of a headache. I'm not going to do that. That takes too much time. It is a headache and it takes time. But if you just do that for a couple of weeks, you will have it. Just be fastidious, compulsive for 2 weeks and count the carbs that you eat. You can count calories too, but I'm more interested in you counting carbs for those 2 weeks. What you'll find is there's patterns. You don't eat 30 endless types of breakfast. You don't eat endless types of lunch, and you don't eat endless types of dinner. Within 2 weeks, you're going to get most of your standard meals. And you're going to find out where your low-hanging fruit is. You're also, pardon the pun, you're also going to find out about how many carbs you're eating. And just that exercise alone, most people will start dropping the carbs because they'll start discovering these little things that they weren't really counting before. Like old Alabama gardener, he made a comment. He said, it's the corn chips. I love these Dorito corn chips. They're my downfall. And once he went through that episode of counting carbs, he realized how much of a downfall it was. He took those out. Just taking those out at 80 years old and not being that heavy, he lost 20 pounds. Then he lost 20 more just with that one item. Now, to get back to your question, Awandro, what I recommend is if you can get to 100, 100 is a good number to stay at forever for most people. Now, I get a lot of people that want to go lower. I was talking with a patient just yesterday who's gone to 50 to 25. One of the things that happens is a lot of us start discovering that we have lean mass hyperresponder status. In other words, our LDL starts shooting up. Now, I've had Dave Feldman on the channel. I agree with him and now with some folks at Harvard and more places that are saying, if your LDL is shooting up because your carbs are going significantly below 100, that's probably not really a problem. But very, very few docs understand that. You go get a test, you see your local primary care doc or cardiologist, they get emotional. And yes, we had one of those. So I'm going in a bunch of different ways to answer your question. Let me just be very specific. I think 100 is a great place to look at for a standard. Thank you, Awandro. It was a great question. Framingham. Thank you so much. I always have these senior moments. And they say, and there's some fairly good evidence, that when you're getting senile, the first thing that you lose is word finding. That's scary to me. So that means, hey, is this my first step towards Alzheimer's? You see, I'm smiling when I'm bringing it up. I had this when I was in the 4th grade. I was the most forgetful 4th grader you ever met. Not only was I forgetful for word finding, I've had word finding problems all my life. I've also been very forgetful. In fact, I'm less forgetful now than I was as a 10-year-old. So I'm not quite so worried about my word finding issues. And thank you, Framingham. For those of you who are not connecting the dots, a couple of minutes ago in the long content, I was talking about the standard ways that the standard medical community evaluates cardiovascular plaque. The first one is, how are you doing today, Mr. Jones? How old are you? How old are you? What gender are you? Do you smoke? Do you have high blood pressure? These are all the doctor's internal version of a thing called Framingham. Framingham is a town, and I go into detail on it in the book. Framingham is a town about an hour away from Harvard in Boston. It is by far the biggest database location of studies associated with cardiovascular disease. There have, in fact, been 5 cohorts. What's a cohort? That's That's a term that came from Roman armies. It's a group of people that travel together. Cohorts in this group means basically 5 generations of people in Framingham have been studied. They're on the 5th right now. In terms of what causes cardiovascular disease, that's where this whole concern about LDL came from, and low HDL. And now there's a lot of stuff coming out about carbs. And just, again, more information about cardiovascular risk have come out of studies and databases associated with Framingham, Massachusetts, than any other place in the world. So there's a thing called the Framingham calculator. And doctors think they know the Framingham calculator, and it's the basic risk factors that they already know: the age, the gender, whether or not you smoke, whether or not you have high blood pressure. That's not all there is to Framingham. In fact, Framingham has been altered to do some things to say, look, you need to sit down with the patient and understand a lot more about their dietary habits and and their approach to their lifestyle, which most doctors just don't do. So even though they think they're doing a Framingham, they're not doing a Framingham. So that's one of the reasons why I'd say, yeah, when you look at the 3 standard ways that the standard medical community looks at plaque, Framingham first, and then, hey, let's go get a stress test. And hey, oh, you know what? We need to do a cath, take you to the cath lab. That is such, that's bad juju. I mean, it's a bad triumvirate. You're going down that slippery slope. You go down that far on that slope, and you're very, very likely to end up getting a stent or even a bypass. And, you know, stents might not be that dangerous. Bypasses might not be that dangerous, you know. And all of those are true. I'm more concerned about people thinking I've been cured by my stent or my bypass than I am the dangers of having a stent or a bypass. But as you saw in the study today, even the big difference between the outcomes on a CT angiogram and a cath lab angiogram is the dangers, the bad outcomes, the boo-boos that happen during the cath lab thing. And most commonly those are leaking and bleeding from the groin, the femoral artery. So again, thank you for that reminder, Iwandro. B. Flint, Framingham. Thanks. I'm going to get a lot of Framinghams here. Yes, it was Framingham. You got it. Framingham, Fort Worth West Side. Wife took calcium score. Had a score of 12. I'm guessing you'd recommend low-dose statin. Yep. Trying to get her to change eating habits. You know, that's the thing. Actually, Fort Worth, it's a very interesting thing. Those of us who've done things like CIMT for a while have had concerns in the past saying, we know that the real risk is soft plaque. It's not the calcified plaque. And the reason a high calcium score shows risk is that it's shown that you've been going through this cycle of inflammation, laying down plaque, and at least in some of your plaque, you've gone beyond the inflamed state and now you've calcified. But it doesn't tell you, and this is the big issue. I know a lot of my audience used to watch a lot of Ivor Cummins. There's not so much overlap anymore, but there was a lot in the past. Cummins always says, no, it's got to be calcium score, got to be calcium score. Here's the problem with calcium score. All of them have problems. CIMT has problems as well. But with the calcium score, it doesn't tell you how much soft plaque you have. And we did a program a couple of months ago which looked at this specific issue. I had wondered about that in the past. Back in 2018, the American Heart Association Standards Committee actually did go ahead and say, look, if you have a 0 calcium score, doesn't matter what else is going on, you don't need to take a statin. So if you know what we know about plaques, how do you know that there's not plaque there, but just soft plaque, no calcified plaque. Well, somebody else asked that question and they did a study. And guess what they found out? A significant number of people with a negative calcium score had plaque and, yes, went on to have events. So I don't know how long it's going to take the standards committee to go back and look at that question of, should we really be telling people if they've got a negative calcium score that they don't have to worry about it? Getting a lot of comments, a lot of interest, and I'm going to be lost for a second as I go back. You know, the way the comments are set up on this thing, if we start getting a lot of them, they'll pile up and then they'll just shoot the list right on up. So sometimes we end up skipping some. I think we found it now. Craig Bax, Dr. Bax, a very good cardiovascular prevention doc in Ohio. The surest way to make a man not understand something is to make his salary dependent upon not understanding it. Upton Sinclair wrote The Jungle. He also, I'm pretty sure he won a Pulitzer Prize for one of those books. Thank you, Craig. It's great to have you on board, and appreciate that comment. You know, in the early years of the show, I didn't go there. I didn't want to get political, and you know, didn't want to cast aspersions. But the reality is the reality. You know, when we wrote the book, we became very clear about what's going on with the medical industrial complex. Black Tengu, is there any truth that full fat, blue, moldy cheese reduces arterial inflammation? I'm not going to be an expert on that. I will tell you, I'm not worried about blue cheese, full fat, causing plaque because again, this issue tends to be much more related to variations in blood sugar than fat in the diet. Now, variations in blood sugar and body fat, not so much fat in the diet. Now, a lot of people are concerned about some of the issues like IGF, insulin-like growth factor, some other things, and making a point that those tend to be associated with dairy products. There's also some association with, and maybe because of that, with prostatic inflammation, but not so much with cardiovascular inflammation. I'm not worried about them. I haven't seen any evidence which would indicate that you should be. On the other hand, I don't think you can just eat blue cheese and make it go away. I mean, you can't. Blue cheese is not going to overcome an insulin resistance problem. Bart Robinson, I listened to an interview yesterday with cardiologist James Min, CEO of Cleary, a new type of CTA, if I understand correctly. Have you heard of them? There are some new types of CTA. They're using artificial intelligence and trying to get better focus points on just where the danger points are within the CTA imagery. And there's a lot of hope for those. There really is. Robert Weiss, intermittent fasting. If you bypass breakfast, when do you take your morning medication? Wait until lunch, then dinner? Need some fat, 2 grams for D3, omega-3. Maybe not significant. I've never really seen it as significant. When I was doing time-restricted eating, I tended to not worry about taking D3 and omega-3s in the morning on an empty stomach. Now, some people may have a problem with it. As my family will tell you, I always had a cast iron stomach. And I really haven't seen a lot of I'm making that all about me. I apologize. I haven't seen a lot of patients that had a lot of concerns or problems associated with taking D3 or omega-3s on an empty stomach either. Bart Robinson, Robert, good question. John Griffin, I have VA. I'll get nothing covered. Yeah, I don't know how we could become a VA covered provider. B. Flint, do you have any thoughts on the rise of sugar bugs? Urinary tract infections and blood infections with COVID. No. One of the concerns that I have is that there may be a little, I'm not even going, I think there's some misunderstandings there, B. Flint. Bart Robinson, correction, the imaging company is spelled clearly. Yes. Well, part of what they're going to be doing is looking at seeing if they can use the AI to show how much actual flow is occurring beyond the pinch points created by the plaque. Here's part of the problem. There's a lot of promise for them, but part of the problem still is the issue. It's everybody looking for that one bad plaque area. And that's what the cardiologist, that's the plumbing problem that everybody keeps going down. It's like, if I get more, it continues to focus on the perception that it's the amount of blockage. And that's not the problem. The problem is the inflammation, how unstable those plaques are. So I think that clearly in some of the other AI-driven focus points on plaque and CT angiogram are going to be steps forward, but I think the bigger step forward is not going to be looking at not going to be looking at how much. We're going to continue. As always, we're human beings. We all assume that we know what the problem is. And logically, it's got to be the amount of blockage. That's not what's causing it. So I don't know if we'll ever overcome that common misperception. That's what the whole stent thing is about. That's what the whole cath lab thing is about. That's what the whole coronary bypass thing is about. It's about plumbing. And this is not a plumbing issue. It's a metabolic issue. So Fort Worth West Side, I was on keto for over a year, and average blood glucose was always about 105 to 110. I changed to carnivore eating and 24 to 48 hour fast. Very, very interesting. Average is now 85 to 90. Well, I'm not surprised. Sometimes you just got to experiment with your body. Yep. And, a lot of people keep saying, oh, carnivore, that's got to be terrible. And most of those people would say, no, it's got to be Mediterranean. Well, even Mediterranean, I think, needs to be modified because some versions of Mediterranean have way too many carbs. I've experimented a little with carnivore, not very much. I'm just not a carnivore kind of guy. I have a few patients, very few, who are on carnivore, and they've done very well with it. So thank you for sharing, Fort Worth. Felix Cat, why doesn't stenting at bypass not reduce events? Seems I know everybody thinks it should, and it's only logical, right? Because everybody thinks it's plumbing. It's how much blockage you have, but that's not what's going on. It's how soft that plaque is. Is it inflamed? Because if it's inflamed, it can leak back out and cause a clot. You see, Felix, it's not the plaque that causes the heart attack. It's the clot. And stable plaque doesn't cause a clot. Inflamed plaque causes a clot. It's really hard to wrap your head around it. I understand. Wesley C., your thoughts on normal range A1C, 4 to 5.6 for under 65. 5.6, by the time you're up at 5.6, unless you've got something going on with all the things that can impact it, like variations in hemoglobin, kidney disease, pregnancy, liver disease, stuff like that. Unless you've got one of those causing it, a 5.6 is usually going to mean that you've got enough insulin resistance to start forming plaque in your arteries. So that's labeled as normal, but it's not healthy. You need to be in the low fives maximum. Okay, so I stopped in the middle of your question. 7 to 7.5 for 65. Oh my Lord, no, So you're telling me normal range of A1C is 7 to 7.5 for anybody? No, it's not. I mean, well, I don't know how you define normal. It's certainly not healthy for a 70-year-old to have an A1C of 7, and that's diabetes. That's one of the criteria. As a 67-year-old, should I just accept that high A1C will go up? No, not at all. If you're over 5.6 as a 67-year-old, you need to be afraid. You need to work on that. And I've got late 60s, early 70-year-olds with 5.1. And in fact, I think my last one was like 5.1, 5.2. I can't ever break that 5.0 mold because I'm more of a 100 gram a day kind of carber. But I may actually break it now that I'm taking this as this GLP-1. It's very, very interesting. But Wesley, I'd suggest, no, you've got some bad information, and these are not healthy numbers that you're listing. Sal Escamilla said no to a stent, took a CT, stable angina, 76, starts to hurt at about 130 beats per minute, calcium score 1300. Sal, you're not alone. I tell you what, though, it's scary. I've been impressed with some of my patients that will call me up and say, you know what, they're wanting to do a stent or they're wanting to do a bypass, and they're telling me and my family that I'm going to die. And a lot of these people are holding their ground, and it's like, whoa, gutsy. It turns out to be the right thing, but it's like, it's part of the story that Lois shared. It's like, if it'd been me alone, I'd have said no, but I've got my daughters over there in the room and they're panicked. So I did it for them. Fort Worth, too bad the blackberry cobblers, ice cream, sweet tea, chocolate pudding is not the food that is good for us. It's so true. So true. We'd be in heaven, wouldn't we? Yeah, we would be. Guepardo. Good morning, Dr. Ford from San Antonio. I lived about half-time in San Antonio for about 3 years. We were building the Toyota truck plant there, and I set up the healthcare system for it. We set up a healthcare system that's very, very different from your standard healthcare system. It was much more. We ended up paying 3 times the amount for primary care than you typically would. But we invested, what was it, like $7 million? We paid for that in, 16 months, 18 months? And here's why. If you get good primary care, good prevention, here's what happened. Our specialty costs dropped. Our emergency room costs dropped. Our hospitalization dropped. That's what happens when you actually focus on prevention and primary care. And you know what? That's what we're doing in the Alabama project. It's a very similar thing. It's focused on Medicare Advantage. And Medicare Advantage, a lot of people think, oh, that's not good. You lose choice. It's an HMO. It's for poor people. Okay, have you seen your Medicare Advantage program today? Or are you talking about your father's Medicare Advantage program? Medicare Advantage has grown from less than 9% of Medicare when I first got involved with it about 6 or 8 years ago to close to 30%, well over a quarter of Medicare now. And it's because, again, modern Medicare Advantage is maybe not what you think. Now, why does it work? Well, it works because it picks the hospital's pocket financially. And that is a good thing. And that's exactly what we did at Toyota in the San Antonio truck plant. If you give people the proper primary care, the proper preventive care, they don't end up going to the hospital and getting overtreated by specialists. And guess what? That's talking all about finances. It's not mentioning once the underlying issue, and the underlying issue is people are not getting sick. So, Keith, are you still a big believer in low-dose Crestor? Absolutely. No question. That hasn't changed. Bart Robinson, yes, the Jump Rope Dudes YouTube channel is great. And the Crossroad jump ropes are the best brand. Oh, they're so expensive. $200, $100 for a jump rope. I'm not quite there yet, Bart. I'm too cheap. Guepardo, my wife got TIA, transient ischemic attack. It's often called a mini stroke or a short-term stroke. On July 2nd at the midnight, I'm sorry to hear that, for a few seconds. Later, TIA was on July 4th. Oh, that's not good. And these are bad signals when these happen. 7:44 p.m., I took her to the emergency room and kept her on the hospital for 2 days. The probability of having a permanent stroke in the 12 months following these is much, much higher. Be very concerned about this and get her some good preventive care. Take a hard look at her body fat content. Take a hard look get an OGTT and insulin response. Take a hard look at her metabolic status, Guepardo. She's been blessed with a strong warning. Don't ignore the warning. Bob Bell, Framingham. Yep, got it. Ezekiel bread. I've seen Ezekiel bread. I haven't tried that much of it. I was actually surprised. It had a lot more carbs than I expected, if I'm remembering correctly. Farouk Farr, good to hear from you, Farouk. Thanks for the information. I learned a lot from you, good doctor. God bless. Unless I'm mistaken, Farouk, aren't you in like Iraq or Iran? And aren't you a doctor? Rachel A. Aldi has amazing keto bread. Best I've tasted so far. Thank you so much, Rachel. I didn't know that. We actually have an Aldi. It's a little bit further away, and I'm really lazy. I tend to do a lot of I'm about a half a mile from a giant Kroger. And you may not know this. I actually worked for Kroger for a couple of years. I was the medical director for the little clinics. That's a whole different story. And it's, again, all about providing good prevention where people are, improving access to prevention. Fort Worth West Side, do people actually reverse type 2 diabetes on low carb eating, or is it really just in remission provided you stick to the lifestyle changes? Exactly what's going on there is a very, very good point. You'll hear Jason Fung and other people saying, quote, you cured your diabetes. Well, you do need to be aware. Body fat is not an inert energy storage material. It is a endocrine tissue, and it causes this problem. So if you drop body fat, you can get dramatic. A 10-pound weight loss almost always results in a huge improvement in OGTT and insulin response testing. So people that come in, they're 30 pounds overweight, they lose that 30 pounds, they can, quote, cure their diabetes. Now, is it in remission or cured? So if they gain that 30 pounds of fat back, they're back where they were. So you define that as a cure or a remission, however you want to define it. As all of us know, you can have people that don't have 30 pounds of fat to lose that still have insulin resistance. The obesity epidemic is driving a huge portion of this, but not as much as aging. It's just that there's nothing you can do about aging, or that you'd want to do. Harvey Ops. We use a great keto bread, no gluten, very low carb, tastes great, even toasts good. Base culture, great for grilled cheese treats. With all this talk about this, I'm going to have to go get a grilled cheese panini with my frozen keto bread. And those of you who are saying frozen, yeah, it's really good. And it lasts forever if you make a panini out of it. So Rachel A., Doc, I just saw my doctor and he was pretty impressed with my questions. I told him I listened to you. He said, keep listening, and he's happy that I'm so informed. I think I impressed him. Well, it sounds like you did. And that's what this is all about. Thank you so much for sharing that, Rachel. Now let's see here. 12:10. Hold on just a second. I'm going to check time. We've got a lot of questions continuing to bubble up. We'll get to as many as we can. Guapardo, they did it. This is talking about the TIA, I think, for your wife. MRA of neck, brain, all her arteries are clear, no soft plaque. They found on the brain MRA, right? MCA, M2 branches are diminutive with poor visualization of the posterior right M2 branches, raising concern for high-grade stenosis versus occlusion. Please advise. I can't, for two reasons. Number one, I can't, give people specific individual advice given, on the internet like this. I'd be happy to see you again, Gilbert, if you want to put up Michelle's number. I'll be happy to see your wife as a patient. The other thing I would say, though, I can be in general, and that is, yes, there can be structural issues. There's no question about structural issues causing some of these problems, but I'll be flabbergasted if I were to hear that she had an appropriate metabolic evaluation. I'm not seeing anything that you've listed so far that would say that. Lucian, NutriSense is great, and also chronometer. Yes. I keep wanting to do a show or a program. Is it NutriSense that now has the glucometer, the CGM, that you don't have to get a prescription for? Lucian P, going under 100 with carbs makes you sick if you're not adapted, which can take some months or years. Well, I'll tell you, Lucian, I did. I had a couple of episodes of hypoglycemia, and hypoglycemia is not fun. You get panicky, you get sick, and you can wreck your bike or your car and do a lot of damage. So you do have to be careful as you start improving your lifestyle. And you're correct. You will adapt back to those normal, lower, healthier numbers. But it doesn't happen overnight. It can take weeks and months. Thank you so much for sharing that, Lucian. Harvey Ops, calcium score was 230. Cardio put me on a residency 10 milligrams, dropped my LDL less than 40. I had him drop ROS. The rosuvastatin to 5 milligrams. Numbers went up slightly. I added niacin, 500 a day, dropped the LDL, small particle count, 350. Triglyceride over HDL is 0.9. Well, good for you. It sounds like you're accomplishing some good stuff. Niacin, as many of us know, can drive niacin is the only thing that tends to increase HDL, decrease LDL, most of all, improve LP(a). And there's a whole debate around that, which I'm not going to get into right now. Also can tend to improve triglycerides. On the other hand, it also tends to push a little bit on insulin resistance. So I don't recommend niacin just for everybody in general. I recommend that, like other things, you take it if you need it. Guapardo, sorry, doc, I was unable to put all information in one message. Got it. We're getting lots of comments, and I don't know how many of these we're going to get to. Jessica Turnbull, hi. Well, a whole lot of highs. We got it, Jessica. Thank you very much. Hello to you. Rick Farnbach, how often should one repeat calcium CIMT tests? CIMT yearly. Calcium score every 5 years. And again, it's because calcium scores only... with both of them, you have to know what you're interpreting. It's a good question. 5 years for the calcium score, 1 year for the CIMT. Old Roscoe, I had my annual checkup last Friday. My doctor said there wasn't any need for blood tests this time. Is every year or biannual the standard for routine lab tests? gosh, even every year is like, uh, you know, routinely we say like every quarter. When people are stable, we'll say, okay, it's 6 months. Because the way I'm set up right now, I'm very expensive. So, I have a lot of patients who say, Doc, I just can't see you every quarter. We'll see you like every 6 months or so. But if somebody goes beyond 6 months, for example, I won't prescribe medications because I need to be able to have some ability to monitor those. Getting lab tests every 2 years is not what I would recommend. Just not what I'd recommend. Rick Farnbach, if I started taking methylated B complex, where would you expect to see changes in my blood work? You actually don't see a lot of changes, Rick. Here's what happens. So methylated B complex is based on a thing called poor methylation. You see that are you a poor methylator on the internet? A lot of people think that's not real, or either maybe it's real, but not significant. Both of those are incorrect. It is real and it is significant. You see things like elevated homocysteine. Routinely, I'll just say, you know what? You could get testing. I used to work at a human genetics lab. I am a poor methylator. There are 3 very common MTHFR, methylene tetrahydrofolate reductase, genetic variations. People that have those genetic variations don't methylate very well. Well, why does that matter? What is methylation? So it all gets back to oxidation and reduction. Oxidation or rust, reduction, the opposite of that. And guess what? We get energy from oxidation. That's what we carry iron in our hemoglobin for. So we can carry oxygen so that oxygen can go to our cells. So the mitochondria in our cells can use that oxygen to oxidize things like carbs and fats, carbon, hydrogen molecules. So you combine oxygen to a carbon hydrogen molecule and break it down. That's how we get energy. Now, you may be aware there are several different mechanisms and theories about aging. One of the most common one is the mitochondrial theory. If you see the mitochondria as like furnaces, then, I'm a 65-year-old. I've got mitochondria, thousands of them per cell in my heart, not so many in different other tissues, but I still have mitochondria. That's how my cells get energy. Well, and mitochondria die and get replaced. But the point is, if you get these old mitochondria, it's just like an old furnace. You get weak spots in the wall, you get burned out, oxidized, smoking embers lying around. That is a major part of aging. So they say, we'll take the antioxidant supplements. That's vitamins A, C, and E. Those don't, and gosh, who has not heard, who watching this channel has not heard of antioxidants? So that's a major, major market space. But here's the thing. If your body does something, it's probably going to do it a lot better than anything you can insert from the outside. And your body does do reduction, antioxidant type of activity. It does it with methyl groups. The methyl groups are kept in a pool in the using vitamin B complex vitamins. So that's what this whole thing is about. If you got high homocysteine, you're probably a poor methylator. You could get some genetic testing. You could do a whole lot of stuff to try to get deeper in that. I don't recommend that you worry about that. I just recommend that you get a methylated B complex, because then you're replacing what you tend to not have enough of. Will that change your blood tests? No, you'll still occasionally get high homocysteine. But you've done it. At that point, I wouldn't react to it other than continue to take the methylated B complex. Harvey Ops, Doctor's Best, sustained niacin uses niatrend from endurance products you mentioned. Works for me and much cheaper. Very good. Very interesting. I'm a big fan of Doctors Best, Jarrow, Thorne, and endurance products. And it's interesting. I did not know that the endurance products had licensed their technology out to Doctors Best. That's a very interesting point. Thank you so much, Harvey. Fort Worth West Side. What happens to the soft plaque when you take low dose statin? It tends to harden. Does it eventually calcify? Yes, that's what we're talking about. It calcifies. Or does it permanently pose a risk? No, that's the whole goal, is to harden or calcify that soft plaque. You know, my most popular video is that one where I talk about reducing my arterial age. And what that's doing is I'm decreasing my CIMT value, decreasing the thickness of my plaque. Now, here's what's actually probably going on. Again, I'm not the only person that's discussed this. Again, a lot of the stuff that people think is crazy, like, oh, you can't reverse plaque. I've had people say that. That's not true. You can. I've done it. And this doesn't mean that I'm just crazy. It's interesting that you see a lot of these things coming from Harvard as well. I used to teach at Hopkins. I've got great credentials. I'm not a nut like a lot of people, might be tempted to think when I say something like, yes, you can reverse plaque. It's just very uncommon. Now, here's what's actually more likely to be going on than anything else. When you quote reverse plaque, what you're doing is decreasing the amount, the thickness of it. Well, you got to understand what is in creating the thickness of the plaque. When you have soft plaque, it's got liquid in it. It's got inflammatory cells, macrocytes, polymorphonucleocytes, immune cells. It's got things called cytokines, enzymes that are trying to degrade, dissolve that plaque. Well, when you get rid of that inflammatory reaction, the cytokines go away, the cells go away, that liquid goes away. So you might not actually even pull the LDL out of the plaque, but you're still getting shrinkage because you're stabilizing it. That's a subtlety that a lot of people just not aware of. Guapardo, my wife, HDL 71, triglycerides 66. That's a good numbers. A1C 5.0. Those are good numbers. Total cholesterol 225, cholesterol over HDL 3.2, LDL 141. A lot of people would say, oh, no, the LDL needs to be 70. I'm not so concerned about that. So the, A1C at 5.0 is a really, really good number. And a triglyceride over HDL ratio of less than 1 is also a really, really good number. Sax girl, horn boy, any thoughts about technetium stress tests? No, I will say, a stress test is still a stress test. Like an angiogram is still an angiogram. If this is a metabolic problem, not a plumbing problem. Staying high for life. And is a small liver focal nodule an issue for this? Should I be worried about growth or infection of blood, sir? It's probably that's not enough information for me to react to if I could. I'm sorry. Steve Mitchum, do statins reduce the risk of stroke? Yes, they do. Gail 716, bulletproof coffee with MCT oil. Medium chain triglycerides. Give you fat for vitamin D absorption and not break your fast. Well, not break your fast. It depends on how you define fast. If defining fast means that you're not taking any calories, then that's breaking your fast. But I understand what you're saying, and I think that's fine. A whole lot of people do think they're not breaking their fast when they do have bulletproof coffee, and I really don't have much argument about that. Technically, it's not true, but you're still accomplishing some great things for your metabolism. Bob Bell, Sax Girl Homeboy, my brother passed the nuclear stress test with flying colors and had a 5-way cabbage within a week. I don't trust it. He's not the only one who's had an event 2 weeks or a week right after passing. You remember, I mean, that's the whole story. The poster boy for that. Oh, I'm blanking on his name. Somebody can help me. He was the world famous host of, was it Meet the Press? He passed the stress test with flying colors and then died a couple of months later. How do we reduce inflammation? Are there any supplements? There's some supplements that help, but by far the biggest, most common thing is people have too much body fat and they eat too many carbs. It's too much blood sugar and too much glucose. Gosh, folks, we still have a whole lot of questions. I regret that I'm not going to be able to get to all of them today. Just come back and join us next week on the next YouTube Live and see if you can get your question in there a little bit earlier. Thank you so much. I'm going to have to run.